topical thing at the moment. The big stuff that is troubling the whole globe and what is worrying many people. And I think many people want to hear a little bit about this COVID vaccination and all the shenanigans to go with it. So you introduce yourself briefly, then let's kick off.
Okay, let's go. So this is a novel virus. The SARS coronavirus 2 came around in China last year, and it's a new virus, and that means it's not recognised by human immune systems. Our immune systems are naive to this virus. So we have to be exposed to the virus in order to generate immunity to this virus. And we need to develop a lot of immunity to this virus, otherwise it's going to carry on spreading. And what we need to do is develop something called herd immunity. So when about 70% of people are immune to this virus, maybe slightly more, maybe 75%, then it's going to stop spreading and this pandemic will be under control. Until then, we're going to have a problem with it. It's going to keep spreading and infecting people. Now, there's two ways to become immune to something. One way is you can actually have the disease. If you actually have the disease, you're exposed to the virus in this case, and the body recognises the virus as an antigen, something the body recognises as being foreign. And in response to that antigen, the body will make antibodies and other immune cells that will eradicate the virus from the body. And then if we were exposed to that virus again, the vast majority of times we would expect to be immune to that virus the second time we were exposed to it. But suppose we wanted to be immune without having had the disease first. This is why we give vaccines. So the vaccine is an antigen that the body will recognise as being this disease, but does not actually multiply in the body to give this disease. So the body is sensitised to the disease without having first had the disease. That's the principle of vaccination. Now, there was no vaccine to this virus at all up until about a week or two ago. So way back in February, people started working on it. And various big pharmaceutical companies started working on this vaccine. So the first company that started working on it was called Pfizer, and they collaborate with another company called BioNTech, which is a German company. And what they did was they synthesized the RNA. Now the RNA is the cookbook, it's the instructions to make the protein. So they synthesized this RNA, it's called messenger RNA. They put it in a fatty globule, and then that is injected into people's arms. Now when it goes into the arm, it goes into a muscle cell in the arm, or it goes into an immune cell in the armpit in the lymph nodes. But this RNA goes into the cell, and then it causes the cell that the RNA has gone into to make antigens which look just like the spike protein on the SARS coronavirus 2. So the body is essentially making its own vaccine, it's making its own antigen. Then the body's immune cells will recognise that, and that means in future, if the body is exposed to the real SARS coronavirus 2, it will be immune to it. It will have the antibodies and it will have the immune cells. So that was the first vaccine that's worked on, and this has now been approved. So it's been approved by the UK government, by Bahrain, Saudi Arabia, Canada, and of course today the United States has approved this vaccine for use. Now it has got some problems. It has to be transported at -70 degrees centigrade. So there's some logistical problems there. And so far in the UK it's only been given out in hospital hubs because we need to keep it fairly cold. But it is very efficient. The efficacy of this vaccine is about 95%. So it prevents 95% of infections. But so far it's prevented all serious infections, and no one's died who's had the vaccine yet. So we could say the vaccine is 100% effective at preventing serious infections. Now the supply for this is ramping up. We've got about 800,000 doses in the UK, and we're expecting a few million more doses. But it is quite expensive. This vaccine is £15. That's about $25 US per shot. So quite who's going to end up getting this vaccine could be limited a bit by cost, but we do know it works, and that has started already. Then there was another vaccine called the Moderna vaccine. This was sponsored by the National Institutes of Health in the United States. And that works in the same way. It's a messenger RNA virus. So it tells the cells to make the antigen that the immune system will recognise as being foreign. And that's good because it only needs to be transported at minus 20 degrees centigrade, which is normal freezer temperatures. The efficacy of the Moderna vaccine is about the same. It's about 95% protective. But again, on the Moderna vaccine, no one has got severe disease or died. But that one's even more expensive. That's £25. That's about $35 per dose. And of course, with all of these vaccines so far, people need 2 doses. Now, there's another vaccine produced from Oxford University and AstraZeneca. And this one works in a different way. This uses adenoviruses from chimps. And what they've done is they've put the DNA, the genetic code to make the antigen, in a chimp virus. And then they give us the chimp virus. And in that way, we're getting the antigen. So we still learn to recognise the SARS coronavirus 2 protein. Now, the Oxford AstraZeneca vaccine is the one I'm really hopeful for, because it doesn't need to be transported in a freezer. We can transport it in a normal cool box the same way we do any other vaccine campaign. So you can get up in the morning, you can get your cool box, put your ice blocks in it, put your vaccine in it, and then you can go away and vaccine for the whole day. No problem with that, just normal temperatures. Now, how effective this vaccine is still being researched. There's actually a paper published on this, and it depends on the dose. So one particular dose of vaccine, if you give 2 higher doses of the vaccine, you get about 62% effectiveness. But then if you give a lower dose of the vaccine first, then a higher dose of the vaccine, that goes up to about 90%. Overall, it works out at about 70% of efficacy. But actually, again, with the Oxford AstraZeneca vaccine, no one who's had the vaccine has got very sick and no one has died. Whereas in the other group who got another type of vaccine, some of those did get very sick, were hospitalised and died. So no one's got sick or died. And the great thing about the Oxford AstraZeneca vaccine is we can make hundreds of millions of these. So the UK is going to get 100 million of them. That can make up to 1 billion of these in the Serum Institute in India. So we can make this very cheaply in huge amounts. And the Oxford vaccine have agreed not to make a profit, whereas the Pfizer and the Moderna vaccine are making a profit. Now, there's another vaccine coming. The Russians have also got a vaccine, which is it's another viral vector. How well that works, we don't know, because the Russians haven't published any data. The next vaccine coming up in the early new year in Western countries is going to be the Johnson & Johnson vaccine. That's another human adenovirus vaccine, and that can be kept in the fridge for 3 months and transported at relatively normal fridge temperatures, which is another really good aspect. But that's not coming along yet. So the big hope I think most of the people in this world are actually going to be vaccinated with the Oxford AstraZeneca vaccine, because it's cheap, it's easy to produce in huge numbers, it's easy to transport, and it's a simple matter to inject it into people's arms without any difficulties. So that's roughly where we're at the moment. The only vaccine that's actually been approved is the Pfizer-BioNTech vaccine. Now, in the next week or two, the Moderna vaccine will be approved in the United Kingdom and almost certainly in Canada and in the United States. The Oxford AstraZeneca vaccine, I'm hopeful that's going to be approved this year, because that's the one that's actually going to save, I believe, most lives in the world, because it's cheap and they've committed to distribute it and they've committed not to make a profit on that vaccine. Now, make no mistake, vaccines are the way out of this pandemic. We have to have vaccination, otherwise this disease is going to go on spreading for several more years. So in the United States, for example, probably only about 15-20% of the population has been infected by this virus. In the UK, it's probably the same. It's probably about 15% of the population. That means that 85% of us could still catch it. And we know that 3 or 4% of the people that catch it get quite sick, and a small minority of those can die. But if a lot of people get the virus all at the same time, it's really important, because that can overwhelm healthcare facilities. And that means people will die of simple things like lack of oxygen just for a few days. So like the British Prime Minister Boris Johnson, he just needed oxygen for a few days and he was okay after that. But without that oxygen, he probably would have died. And if millions of people are trying to access healthcare all at the same time, people could die from simple things like lack of oxygen, lack of steroids, lack of antibiotics. So that's why we need to get this under control. And the vaccine is the way out of it. And I believe with mass vaccination, the numbers of this disease, COVID-19, is going to start going down quite dramatically. And I'm really hopeful that the Oxford AstraZeneca vaccine is the one that's going to be rolled out throughout Africa to generate the herd immunity in African countries as well. Because at the moment, richer countries are like taking the vaccine for themselves and not bothering to vaccinate anyone else. And that's one thing that needs to change. So that's where we're at. The future's looking good. The case is, how long is it going to take and how many people are going to suffer and die in the meantime? I think that's roughly where we're at now at the moment.
Okay, that's fantastic. That's a very good summary of what vaccine is and where we are at the moment. Now, there are some questions, probably a lot of misinformation, a lot of conspiracies out there. Now, because this is a messenger RNA thing, and the people are worried they're going to mess up with the DNA,
yeah.
It's going to change,
yeah.
humanity and that kind of thing.
Yeah.
So, what is your take on that?
Right, the answer is a really simple answer to that, Naz. In biology, we have a saying, it's more than a saying, it's a rule. DNA makes RNA, makes protein. It doesn't go the other way round. So this is an RNA vaccine. The RNA will make the protein that will be the antigen that the body will recognise as being foreign. But there is no enzyme to make the RNA go into the DNA. So there's no way at all, it's biologically impossible for this RNA vaccine to affect the DNA that is in our cells already. It's biologically impossible. Forget about it. If anyone starts talking about that rubbish, walk away. It's not possible.
Okay, thank you very much for that. And again, I think some people, especially from the black and I think minorities, they're worried that there's not enough sample included in the test of this vaccination. So people are a little bit wary about the whole vaccine. So again, there come a lot of conspiracy theories and stuff.
Yeah.
So what do you think?
Yeah, there are interesting factors to do with race and ethnicity with this virus in general. In America, about 4 times more black Americans than white Americans are dying. And about 3 or 4 times more Hispanic Americans are dying compared to white Americans. And I think one of the reasons for this is that the darker colour your skin, the more slowly you produce vitamin D. So I can produce vitamin D quite quickly in the sun. The darker the colour of the skin, you produce less vitamin D. And we know that vitamin D is a very important immunomodulator. It can increase the immune system to produce resistance to the virus, and it can tone down the severe inflammation that can cause the severe respiratory problems with this virus. So that's one difference. There's also differences between Africa and Europe. So in Africa, the demographic is younger. There's a lot of younger people around. And it's also believed by some people that the fact that parasitic infections are more common in Africa has actually boosted African immune systems. And there's some cross-immunity between parasitic infections, probably including malaria, but certainly the worm intestinal parasitic infections, helping people to have immunity to COVID-19. Whether that's true or not, we don't really know yet, because this virus is spreading more widely in Africa now, particularly South Africa is badly affected. The other thing about ethnic groups in the UK is very often Asian communities and African communities who live in Western countries have other comorbidities. For example, diabetes is more common. Things like prostate cancer is more common. Heart disease is more common. And that these comorbidities could be increasing people's risk of the disease. So some interesting factors there. So there are racial differences, less people dying in Africa, but more black and Asian people dying in the Western world. As regards the specific issue about the vaccine, the Pfizer, Moderna and Oxford people have been very, very aware of this right from the beginning. And they have taken pains to recruit people now all the people that have been recruited so far have been over the age of 18. So we don't know how any of these vaccines work on children. We don't know how it works on pregnant women. But from 18 to old age groups, people in their 80s and 90s, it's been tried. People of Hispanic origin, African origin, Asian origin, and people with comorbidities have all been included in these vaccine trials in their thousands, literally thousands. So we know that the immune response is equally good if you're African origin, Asian origin. In fact, what's surprising with this vaccine is it works just as well in older people. That was really surprising, because normally the immune response goes down, but with the Pfizer, the Moderna and the Oxford AstraZeneca vaccine, the immune response is almost as good in people over, into old age, into their 80s. So in terms of racial differences for the vaccine, I have no concern at all. You've got to bear in mind that all human DNA, we're 99.9% the same. We're all sons of Adam, daughters of Eve. We're all very, very similar. And the main difference, I think, really, is the lighter skin produces vitamin D more quickly. Okay. And I really feel this is a message we need to get out to anyone who's darker coloured, especially if they're not getting much sun exposure, to check their vitamin D status.
Fantastic. Thank you very much for that. Thank you. There's someone raising their hand, Petronella. You can unmute yourself and ask your question, please.
Thank you so much. Thank you so much, Dr. John, for very informative evening. My question here is about the efficacy of the medication and current studies that have been done. So far, the vaccine is new to us because you're using genetics, basically, forensics, genetics. And this is completely new compared to previous vaccines that we knew in the past. And not only that, we know the synthetic messenger RNA has been synthetically synthesized, yes, and being introduced in our body. And the way how we know, like messenger RNA has got a single strand, which will have to react with our DNA, the helix structure. In terms of coding, if it goes to the wrong, if it goes to code in the wrong way, it may cause mutation and cause other effects, severe effects to our health. How can you prove to us that the studies have been done are sufficient enough for me and my society, plus the community in general, yep, to be exposed to this vaccine? Second, yep, will this vaccine be mandatory to all of us, particularly for us who are traveling back and forth in our countries? As I can say to you, my country is free from pandemic. We have pandemic, but we've been told it's free from pandemic. So, however, that said, I know it's a political thing, but I'm just saying, will I be imposed to be taking these vaccines? Yep. I will appreciate your feedback on that. Yep. Thank you very much.
Two very good questions. Right, the reason that I believe these vaccines are safe, the Pfizer one that's been authorised today, partly it's because the MHRA, the Medicines and Healthcare Regulatory Authority, have looked at this very carefully. They're happy. The FDA in the United States have looked at this very carefully and they're happy. And they're getting data every day directly from the manufacturers as these trials go on. So these very august bodies are happy with the safety. The reason I'm happy is that the 3 phases of clinical trials have been gone through, the same as with any new drug. So any drug you take, any vaccine, you have phase 1, phase 2, phase 3 clinical trials. The phase 3 clinical trial is the big one where it's compared against a placebo. So some people are treated with the vaccine and some people aren't. And for example, with the Pfizer vaccine, we know that there's 95% fewer infections in the people that get the vaccine. And we know that none of them were really very sick. Now, your concern is about the RNA, the messenger RNA. And as you rightly say, this has been artificially put together. The bases of the RNA have been artificially put together, put in a fatty globule and injected into the arm. So they go into the muscle of the arm and they'll go into the lymph node. And there the RNA will give the protein-making machinery in the body the information it needs to make these proteins, which are exactly the same shape as the SARS coronavirus 2. That is what sensitizes the immune system. But this RNA is not produced inside the cells. The RNA that's given will degrade over a few days, and a week after the vaccine it will simply not be there. But that's okay, because it will have done its job. It will have made the antigen that the body recognises to make the vaccine. So the RNA itself will simply deteriorate and it will just fade away. The body's not producing it anymore. And inside cells and outside cells you have scavenging systems that take this sort of thing away. That's well recognised in biology. Now the RNA that we're giving, you're right, it's a new technology. This has been done before investigating cancers, to try and treat cancers. But you're right, it's never been done before in a vaccine. But all the RNA is doing, instead of saying, well, here's your dinner already made and cooked for you, what it's saying is, here is the recipe book, go and cook your own dinner. It's the recipe for the cells to make the antigen. There is absolutely no mechanism whereby the RNA that you give into the outside part of the cell, the cytoplasm or the cytosol of the cell, there is no mechanism for that getting into the DNA that would replicate inside the cells. There is no mechanism for that. Now this does happen. I think part of the reason people are worried is this happens with HIV, the human immunodeficiency virus. But that virus has got a special enzyme called reverse transcriptase that can convert RNA to DNA. This vaccine does not. It is quite impossible. The RNA will simply go away after a few days. So we know from trials and we know from basic biology that this is safe. Now, the idea of mandating a vaccine won't happen from any government that I know, but some airlines will probably say you have to have the vaccine to travel with us. Some countries will say if you're not vaccinated against COVID-19, you can't come into this country. This is true with many African countries at the moment with yellow fever. You need a yellow fever certificate to get into the country. So this is nothing new. Some employers may say you can't work for us unless you're vaccinated. You have to be vaccinated to work for us. So you're right, there's going to be some of these social pressures, but it's not going to be legally mandated. But you're quite right, it could become essential for certain types of employment, for certain types of travel, especially international travel.
Sorry, just to add on that, Dr. John, there is conspiracy going around that the vaccine will have a code, and this code is on religious beliefs like 666 or whatever, or Lucifer, I'm so inquisitive to understand the logic behind it. And not only that, another thing is I did ask about sufficient efficacy studies, because there have been studies done in cancer, but yet there hasn't been cancer vaccine as we speak on this technology. And also we have heard that there is a lipid layer or nanotechnology which is being used on this vaccine, which apparently is used in army, and it can track you wherever you will be and manipulate you to work as a robotic individual. Is there any truth about it? Are you worried about it?
The answer is absolutely none at all. When you have conspiracy theories, there's two things keep coming up. One is the Knights Templar, and the other is 666. Now, 666 is the number of a man. It's a code in the book of Revelation. It's nothing to do with this vaccine at all. Absolutely nothing to do with it. The lipid layer around about the RNA is essential. Now, the RNA itself is a single strand. Imagine that is the RNA, that pen. Now, that is water soluble. That can't get into the cells because the cells are surrounded by a fatty membrane. So you have to put this water soluble RNA into a globule like that of fat. So it's inside the fat, because it's only when something is fat soluble that it can get into the cells. And because this fat is not reproduced, it will be deteriorated again within a few days, and it will be as if it was never there. The idea that fat, and this is fat, this is a fat globule, the idea that fat could carry information is ludicrous. It's a repeating molecule. It's not like a protein where there's alternative amino acids. It's not like RNA. It's not like DNA. It's a repeating molecular unit, and it can't carry information. and there are no drugs. There are no drugs that can be given that can control your mind. You have free will to do what you want, and there's no drugs or medication that can change that. So don't worry. And the idea that a fatty membrane can somehow track your position, again, this fatty membrane will deteriorate in a few days and it will no longer exist. It will have got the RNA into the cell, it'll have done its job. The cell's internal scavenging mechanisms and the external cell eating systems, what we call the phagocytic systems, will just get rid of it altogether and it won't be there anymore. Mobile phones can track where you are, but vaccines certainly cannot.
Good.
It's an important point, Naz. You know, there's so much disinformation going around. And all you've got to do is apply a little bit of really basic science, and most of it just disappears. And but the point is, people could die by not taking these vaccines. It's a real problem.
Yeah, and that's why I thought it'd be very important to talk about it. Because
Absolutely,
people are running scared. It's something which is for saving lives. You know, some of the stuff does not make sense at all.
We've been vaccinating for 200 years. You know, this is a more sophisticated vaccine. But, you know, Edward Jenner gave the first vaccine to James Phipps in 1795. Well, it wasn't quite a vaccine, but it was nearly a vaccine. You know, we've been doing this for a long, long time, and you know, a lot of vaccines were developed at around about 1900. So, well over 120 years we've been vaccinating for. This is a well-known medical technique.
Yeah, and I know some people are worried that, okay, why the UK, the first one to authorize this, they're just jumping the gun. But I think people forgetting that because the UK or the NHS was the first one to do like a BCG was the first in 1949.
Yeah.
But the first one is started here, and in 1988 the MMR started in the UK, and we have meningitis C in 1999.
Yeah.
That's why from the UK they was first as well.
Yep.
So having COVID-19 vaccine, UK or the NHS being the first is not something new.
There's another reason, Naz. The Medicines and Healthcare Products Regulatory Authority in the UK, they didn't wait till the application for Pfizer-BioNTech was made on the 23rd of November. But they've been analysing this data since the 1st of October. They anticipated this. So this analysis was already about 7 or 8 weeks old, thorough analysis by the best statisticians, the best vaccinologists, the best virologists. And then when the vaccine came along, after the official application, it only took 10 days to approve it, but that was after 7 weeks of studying it already. So they really hit the ground running. They were proactive. That's why they were so quick.
Fantastic. Now, thank you very much. For any more questions, please, if you have a question, please raise your hand. You can put in the chat room there. Or Imani, are you still around? Dr. Kondo?
I'm here.
Okay. Do you have anything to add? You can add anything in Swahili or in English, whichever way. Tupo wa Kiswahili kwanza. So kama kuna wasikilizaji ambao hawaelewi Kiswahili, kama Charles haelewi Kiingereza, hebu muelezee kwa Kiswahili kidogo.
Okay, fine, good. I will start with English just to thank John, because his presentation was quite comprehensive. So I have just very small bits to add on. Really, he's done all the job. So thank you very much, John.
Pleasure.
Yeah. So I just want to add with the difference between the Oxford vaccine, and one of the reasons that it's going to be more useful than the Pfizer vaccine is that the Oxford vaccine, when they were preparing the vaccine, they also checked whether or not it prevents asymptomatic infections. So the Pfizer vaccine, they didn't check that. So we know that Oxford vaccine does help to prevent asymptomatic infection. So you sometimes have the virus, but you don't have any symptoms. And if you have the Oxford vaccine, we know that it stops you from spreading the virus even if you don't have symptoms. So that's another important thing to note.
It's a good point. They did regular antigen tests on 7,000 people in the UK. It's a very good point. It's good point. Yeah.
And another thing that has come up after the vaccine started to be used is some people tend to have severe allergic reaction to the vaccine. So although it's been, propagated as, you see the vaccine now is causing allergy, but that's the case with any new medication you use. So if you've never had penicillin, for example, if you have penicillin for the first time, you could show allergy to it and it can be very severe. And sadly, you may even die. So this shouldn't be taken as, it's only happening because of this new vaccine or because of messenger RNA or because of anything out of the conspiracy theory. It's new science. The body can react to something new in a way that you don't expect. So
and the two people that had the allergic reaction knew they were allergic to multiple things as well. It didn't happen in the trial because they excluded people with known allergies. So for now, we're just not giving it to people with known allergies.
Yeah, good. So
yeah, good point.
Another thing is, having said everything, this is new vaccines. It's new disease, new virus, new vaccine. So nobody can tell you confidently that they're sure that there is no any long-term effect. So that one is not known. It's not known to anyone. But because the world now is at danger of this pandemic, we cannot say we have to wait to test this vaccine for 20 years before we can use it, because by then maybe half of us will be dead. So we don't want that to happen. So we'll use this vaccine because so far all the studies to check whether or not it's safe has proven that it is safe to use. And it's something that will take us out of this pandemic and we can go on with what we consider to be normal life. And I'll just add on a little bit about the what Petronella asked about the nanoparticles. Well, so the conspiracy about the nanoparticle comes because the word nano is very much used in technology, nanotechnology, but it's pretty much a Latin word. Nano means very small.
That's all it means.
So nanoparticles, the nanoglobules, the fat globules, they're nano because they're very small, and they're very small because the mRNA that they need to carry is also very small. And because the particles are small and mRNA is very small, then it can get into the cells easier because then they don't need to dissolve large part of the cell to get into the cell. So they become, the availability to the cell become better if you use very small particles. So the word nano should not confuse people, and they shouldn't allow themselves to be deceived by the conspiracy theory teams. So that's pretty much all I would add on that. Thank you very much, John.
Good, thank you.
Thank you very
good points.
much, Dr. Kondo. I think Said Kindi got a question, so you can unmute yourself and ask your question, Said.
Yes. Assalamu alaikum.
Alaikum salam.
I came a bit late, so I didn't hear everything what Doctor said. But from what I hear, in fact, what I hear that he's trying to calm everybody down about the induction. But my question to him is this, and this is exactly what everybody's talking about. The people who actually create this conspiracy are not people from the street. These are big doctors. And majority of us are not technically, we know more about the thing. Even if you tell me a lot of technical things here, I would catch one or two. Nano, this, I don't know. But the point here I'm making, why this vaccine looks suspicious, because actually it is forced upon us indirectly, not directly, indirectly. I think he said that at the end it will be slowly being introduced. If you don't have this, you can't work. If you cannot travel. So it will put us in that position. And the people who make this conspiracy are not people from the streets, not myself, not anybody, are actually doctors. What happened to these doctors who actually talking to us and telling us the problem of this vaccine? And the other thing which they're talking is that there's a lot of disease, including AIDS and cancer and all the other things. They couldn't come up with a vaccine with 100% or 90% proof, not even 20% proof. This one has been actually developed maybe, I would say, a year or a year and a half. And it has been given about 90 to 95% success, which just makes also doubtful. Malaria injection has been being developed over and over for almost maybe now 50 years. And I think it's about 60, 75%. I'm not quite sure the percentage, but there's no medicine has reached according to this. This is what makes me and the majority of people who have no knowledge about medicine suspicious. Okay, this is my question. I just want to oppose it. I'm at work, so I might be out of village, but I'm at work here. But I found this is very important. That's why I want to put my question forward. Thank you.
Thank you very much for your question.
Do you want me to take that, Naz?
Please.
Yeah. There actually aren't many doctors are saying this vaccine is not. The vast majority of doctors in the world agree with this vaccine. Now, doctors are like anyone else. Some doctors can be a little bit strange. Some doctors can be a little bit insane. Not many, of course, but a few can. And the trouble is that the ones that have got these extreme opinions, and there are very few, 99.99999% of all the doctors in the world are more than happy with this vaccine. But the very few that do speak out against the vaccine, these are the ones that get publicity. These are the ones that people hear about. What you don't hear is all the sensible doctors, like the two doctors we have here, who agree with this vaccine. 99% of people do. So I don't agree with the statement that many top doctors are saying this vaccine's wrong. They're not. All the doctors I've talked to think this vaccine is great. Now, the HIV, the human immunodeficiency virus, there's no vaccine to that because it's a very rapid mutator. HIV is constantly changing. So you make a vaccine against one form of HIV, and by the time you get it onto an injectable form, the HIV is changed and it no longer recognises it. Very fast mutator. Whereas the SARS coronavirus 2 is actually quite a slow mutator. There are mutations in there, but the mutations that have happened so far have not been sufficient that the body's immune system won't recognise the virus and that the vaccine won't recognise the virus. So there is no comparison at all between trying to develop a vaccine for HIV and trying to develop a vaccine for SARS coronavirus 2. Two completely different types of virus. So just remember, nearly all the doctors in the world think this vaccine is great. There might be one or two doctors who don't, but the one or two doctors who don't are the ones that get the publicity. That is the problem.
Okay, thank you. I think Dr. Kondo, you have put your hand up. Okay.
Yeah. I just want to add on that. In a situation like this, no one would listen to any doctor who comes on the internet or anywhere and says, "Oh, I have a vaccine." So this is not a situation where you listen to an individual. If a doctor comes today and say, "Yo, I have a vaccine," nobody will even listen to them. They will not waste their time. If a doctor comes and again says that vaccine doesn't work, you shouldn't even listen. You shouldn't even pay attention. What to listen to is research teams, research bodies, and regulatory bodies. Those are the ones that will say this is not a one-person job. Somebody can say, "I've discovered vaccine." One person does not discover vaccine. A vaccine is discovered by a team. So listen to the credible teams. This person who says this vaccine does not work, do you know any research body that person represents? And that research body, has it done anything in this world? Has it published any work on vaccine? Don't listen to individuals. You can get easily, carried away by some fake news. But research bodies, the good thing is you can easily search to see what they've done. If MHRA, they say something, MHRA has been there. It's a regulatory body. It's trusted by the government. It is accountable to what it says. The same with research bodies. If Oxford University comes and say that we've done something, it's not one person coming on the internet and claim that they have discovered something or they don't approve of something. Thanks.
Yeah, and I think it makes perfect sense because there's no country that will go out of its way to produce something to harm its own people. And I think there's nothing like that. That's insane. I mean, it doesn't even happen in films. So I think we should be very careful what we read or watch or listen on the internet. There are a lot of stuff out there going on the WhatsApp messages and on YouTube where people coming out to claiming to be doctors because anyone can put a white jacket on and just come there and say, "Okay, I'm Dr. So and so," and this. How can you prove that those people are doctors? So I think we should listen to the authorities who have the right information for the people to give us what we need to know. I think Petronila, you have you got your hand up again. Come on, nasikiliza.
Can I just add to that?
Yes, please.
We were caught out in the UK a few years ago. There was one doctor who had a study which he said that a vaccine we'd been using for children, MMR, mumps, measles and rubella, a very effective vaccine. He suggested it was causing autism and symptoms in children. He had a very small study. There were lots of flaws in it. Eventually, that doctor has actually been struck off the register. He's now set up a private clinic in the States. But as a result of what he did and the publicity he gained, the rates of vaccination in these children fall, and there are now a significant number of children who have died, particularly of measles, as a result of his actions. And it's so I think we've got to be very careful listening to people who go against the body of science that John has explained, that actually, you know, one strange voice against thousands of doctors and universities and academic institutions. We should not give it pay it any attention.
Okay. Point. Anyway, Petronila, you have a question. Carry on.
Yes, just a quick question.
Yes.
I recall, Dr. John, you did touch base on the society, population in Africa, more youth, and they have got strong immunity due to exposure to different diseases, and also they've built a lot of immunity. And that said, looking on the vaccine is being rolled out throughout the world. Will that be mandatory for each government to take it on board? And another thing is, you touch based on the studies which have been done on vaccine, which excluded the younger generation. Now, I have my children from, let's say, 0 to 18. Will they be pushed to go through that? As we understand at the moment, these children, they need to attend school, they need to use commute to various places, and at the moment we have heard the government have people in tier 3 may start. We may start having massive testing. Mass testing.
Yeah.
So my question is, how can I be reassured that this vaccine are safe for my children, particularly if the studies were not done to that category or group category? Thank you. I hope you got me.
Yeah, I've got that. Your first question about governments. No government will be forced to take this vaccine, but all governments in the world that I'm aware of are desperate to get a vaccine to vaccinate their people. So governments want this, and then it's up to governments how they roll that out. But as we've said, I don't expect this to be mandated by governments, but it could be necessary for some sort of jobs. Now, is this vaccine safe for children under the age of 18? The answer to that question is no one in the world knows the answer to that question, because the research has not been done. The research was only done on people over the age of 18. And the only reason we know it works in people over the age of 18 is because the trial data has come back. We have the results of the phase 3 double-blind randomised controlled trials. This vaccine has not been tried in children, so we simply don't know at the moment. So we can't say it's safe, we can't say it's not safe, we don't know. Now, the trials are now being done by the Pfizer and Moderna vaccines. They've extended their trials now to under 18s. Now, they would only do that if the regulatory bodies thought it was safe to extend it into that age group as part of a clinical trial, so that is now being done. It's only when we get the results of the vaccine in under 18s that we will know whether or not it's safe for under 18s. Until we get the trial data, we don't know. So at the moment in the UK, because there's no trial data, we will not be vaccinating pregnant women. We will not be vaccinating those under 18 because they simply weren't covered in the trial. Having said that, people under the age of 18 are just as human as people over the age of 18. So I'll be very surprised if there was a difference. I don't expect there to be a difference, but we don't know until the trial data is done. And any government in the world who started vaccinating children until those phase 3 clinical trial data are in would be irresponsible. And I don't think any government would do that. So we're waiting. I'm optimistic it's going to be fine, but we can't start doing that yet because we simply don't know till the trial data comes in.
Okay. Thank you very much. I think that we have someone called Christian Henjewele. Get his hand up. So, Christian, fire away. Yes.
Hello, here I am.
Yes, Christian.
I am reading from this website here, and the claim is that's coming from a team log. The website is called medscape.com.
Yeah.
And they are telling us, the claim is that they are Coronavirus Resource Center. Now, what they're saying in their website is that the new trial has been now published in the journal, The Lancet. And in the journal, what it says is that when they tried the full dose, the efficacy was 62.1%. And when they tried the half dose, the efficacy was 90%. Now, I just wanted to understand how true this publication is. And if this is the case, so what are we taking? Are we taking the full dose or the half dose?
Yeah, it's a very good question, and it is correct. This is the Oxford AstraZeneca vaccine. This paper reported on the phase 3 clinical trial. It was a fully peer-reviewed article, and it was published in The Lancet last week. Now, what happened was about 3,000 people got a lower dose of vaccine first. It wasn't exactly a manufacturing error because it's quite hard to get the right number of viral particles. But what happened was about 30,000 people in the trial got their first dose of vaccine and they got 50 billion viral particles. 50 billion. And then as their second dose, they got another 50 billion viral particles for their second dose. And the difference between the amount of people in that group and the placebo group getting the infection was a 62% efficacy. So a relatively low level of efficacy, but a very useful level of efficacy nonetheless. That was with the large dose and the large dose. Now, a small group of people only got 22 billion viral particles for the first injection. And they wondered whether to include them in the trial or not, but the regulators decided to include them in the trial, as we say, about 3,000 people. So they got 22 billion doses for the first dose of vaccine. Then for the second dose, they got 50 billion, the full dose. And the efficacy there was at 90%. So it looks like giving the half dose first and then giving a full dose after that is better. Now, it's a relatively small sample size, so we need more, but it's looking like that could be the case. And it could make sense in terms of the immunity, because the smaller the dose means that the people got a smaller dose of the viral vector, the chimpanzee adenovirus vector the first time, so they would not mount such a vigorous response to the vector. Whereas if people got the bigger dose the first time, they build a bigger immune response to the vector. That means when they get the vector the second time, the immune system might have destroyed a lot of the vector cells, therefore not as much of the cells will get into the body. So it could make sense in terms of immunity. Now, in terms of how this is actually done, this is with mRNA at the moment, and it's with the FDA at the moment in America, and it's with the European Medicines Agency, and they're going to have to decide that. They're going to have to decide whether the first dose should be the 22 billion viral particles followed by the 50 billion viral particles, in which case we would hope for 90% efficacy, or whether we're going to go for the more tried method of 50 billion viruses followed by another 50 billion. We'll have to decide what they want to do. But, and it's a really important but, whether people had the small dose followed by the big dose or the big dose followed by the big dose, none of the people that got that vaccine got seriously ill. None of them went into hospital and none of them died. So you could argue that this vaccine is 100% effective at preventing severe disease. So if I get a mild disease, I don't mind too much. I don't want to get a severe disease. I don't want to be hospitalised, and I don't want to die. So it looks like this vaccine, in either form, is going to protect me against severe disease, and that's going to be the important thing.
Fantastic. Thank you very much for that, John. Any more questions, people? Because we have done about an hour and about 10 minutes or so, so we're just about to wrap things up. I'll go back to Dr. Charles Campbell. Do you have anything extra to add on that? And
I just think I've learned an awful lot listening to John, so that's great. I am training to go back to work as a vaccinator. One thing I would say is the severe reaction to a vaccine, which is called anaphylaxis, it happens in less than one in 1 million cases. All the vaccination centres in the UK are trained and ready, and if it happens when people are ready to respond, the people will almost always recover. It's only when anaphylaxis happens away, and that's the same reaction people who are allergic to nuts might get from eating nuts, or people who are allergic to bee stings might get from bee stings. But anaphylaxis, even if it were to happen in a medical setting, can be managed. So I think it's really, compared with the risks of the disease, as John said, the risks of vaccination are tiny. And I certainly will be having my vaccine as soon as I come to the eligible list.
Me too.
Fantastic. Dr. Kondo, final words.
Yeah. Final words. Well, what I would say is we all saw that the pandemic quite disproportionately affected the black minority ethnic people, and it's a bit of a shame to see that there's a lot of conspiracy spreading around in black and minority ethnic groups about the vaccine. I would expect now the black and minority ethnic group to be happier than any other group that the vaccine is here. So I call to all people, go get vaccinated, go at home, be safe.
And I really think the vitamin D is a big message that hasn't got through. You know, we know from large-scale studies in the United States that black Americans have way lower vitamin D levels than white Americans, and it's just something that governments don't seem to be taking on. We need to get this vitamin D message through because it is an important immunomodulatory molecule. Vitamin D receptors are present in all of the white blood cells, and they're there for a good reason. We need the vitamin D.
Fantastic. I think just one last show of hands from Christian Hejuele. Christian, swali la mwisho. Karibu tufunge kikao. Karibu.
Hello, asante kwa kunipa tena nafasi ya kuja swali la pili. Now this is about the vitamin D. I remember last time I went to see my GP and my vitamin D levels were really low, and there was a recommendation for me to take the vitamin D supplement, and I've been taking that ever before. But now the problem I'm experiencing is that there are people who are saying, well, the dose I'm taking is still too small. And I was just wondering whether there is a recommended dose for someone who was born and raised in the sunnier places like Africa, Tanzania. What should be the recommended dose that we need to take? Is there an upper limit?
Where you were born and raised doesn't matter. It's how much sun exposure you've had in the last 3 or 4 months that's the key issue. So if you're not exposed to much sun, you would need a higher dose. If you get some all over exposure with your shirt off, you get a fair bit of sun, you would make it more quickly. But if you think of me and Naz, if you look at our respective colours, in the sun I will make vitamin D about 20 times quicker than Naz. And that is the big difference. So we could have the same sun exposure and I could have normal levels and Naz could have low levels. But then again, if we go to the tropics, I would get sunburnt and die. You know, it's a relative risk. But so the darker the skin, the less vitamin D, and the sun exposure is vital. It also depends on your body mass index, because vitamin D is a fat soluble vitamin. And when you take vitamin D, it fills up the fatty parts of the body first before it goes into soluble vitamin D in the body. And you're also best to take small amounts of vitamin D regularly rather than take large amounts. So what we normally say is, and you can't generalise on this, but we believe that, I, at the moment, I am taking 2,000 or 3,000 international units a day. That is between 50 and 75 micrograms. Ideally, what you would do is you would get a blood test and diagnose how much vitamin D is in your blood. Then you would take a supplement for maybe a month or 2 months. Then you would get your blood levels checked again, and then you would titrate the vitamin D levels with the blood results. Some people might need 1,000 units a day to keep topped up. Other people might need 6, 7, 8,000 units a day to get topped up and then to maintain their levels. So there is no one size fits all. But it's important to know that the studies have shown that the people with the very lowest vitamin D levels are more likely to get severe disease. So even increasing your vitamin D levels a bit is going to be helpful. So what have you done for the past 6 months? How much sun have you had? How much fatty tissue have you got? All of these things are going to vary. I'm taking 2,000 to 3,000 international units a day throughout the winter time, and I think that's a fairly conservative dose. Most agencies say don't take more than 4,000 international units a day, which is 100 micrograms. So what I would say is don't take more than that unless your doctor tells you to.
I've just looked at the NHS general guidance about vitamin D, and it actually says 10 micrograms a day between October and March for bone and muscle health.
That's right. That's the dose you need to prevent rickets.
Yeah, basically, yeah, to prevent rickets and osteomalacia. So I think probably John's talking about higher doses in the areas of maintaining immunity or stimulating.
Absolutely. I mean, those doses are the minimum dose to prevent rickets. We don't want to know the minimum levels. We want to know the optimum levels. And studies have shown that people who have the lower levels do get more. There was a study in Spain, for example, that showed people with good levels of vitamin D less likely to be admitted to intensive care. So those levels are very low, and we're actually trying to get the government to increase those levels at the moment.
Fantastic. Thank you very much for that. We'll get one more hand from Dr. Mlawa. Come on, Dr. Mlawa, unmute yourself. And
so I just want to make some comment with regard to vitamin D. I'm a consultant in diabetes and endocrine, and I look after a lot of patients with endocrine disorders, including metabolic clinics. That includes people with low vitamin D. So most of my patients who are Asian or African, the majority of them, they've got low vitamin D level. And I would say that to try and answer Hinjelewe's question in terms of what's the recommended allowance for the day, is about 2,000 units, what John just said. And in terms of how do I treat my patient with low vitamin D, in terms of dosage, it depends upon the blood level of their vitamin D. Some of them, they've got very severe vitamin D, maybe a level of 20. And these patients, they need loading dose of vitamin D. We give them higher dose, maybe for 12 weeks, and then reassess. But some of them, we just use titration regime. As John has said, it's about maximum up to 2,000 units per day. Or in terms of microgram, you can start from 25 microgram to 50 microgram, then keep monitoring the blood test.
okay, fantastic. Thank you very much for that, Dr. Mla. And I think it will be a very, very productive evening. And thank you very much, Charles. Thank you very much, John. And it has been a pleasure to have you guys on board. And hopefully we're going to be able to have you on again for another talk, either about COVID or something else. I think, what can I say? I just feel so excited and so happy. And I hope today's conversation have just reassured a few people who have been kind lost in the mire of misinformation out there. So I think the vaccine is very safe. Okay, John, I think you guys get your hands up.
Yeah, I was just going to say, if people hadn't been looking at the chat, some of the questions that have come up that weren't spoken, but we've answered them as we've gone along. So it may be that people will find there's things in there, and someone says it's I think the chat is actually saved, isn't it? So people can look at it
Yes.
later on.
Yes, I will create some of those and from the chat, and I will just publish them on our Facebook page and our website as well. So some others, which is great. All right, okay. I think on that note, we'll close the meeting from here, and until next time, thank you very much, everyone. Thanks for joining us. Asante sana.
Thank you,
Asante
Chairman.
sana, John. Asante, Charles. Asante, everyone.
Thank
Good night.
you.
Been a pleasure.
Bye.
Bye.
Asante sana.
Thank you so much. Bye.
Thank you.
Bye.